coisa. Agora vou pôr assim ali. Já temos 21 pessoas.
Boa tarde, professor. Está-me a ouvir?
Estou sim, senhor. Boa tarde. Só um segundo, que eu estou a tentar aqui buscar o meu. Pronto, agora tenho que buscar aqui. Muito bem. Rui, estás aí?
Estou sim, professor.
Pronto, ótimo. Então faltam ainda 4 minutos.
Sim. Diga-me uma coisa, professor. O professor tinha-me falado nos dois palestrantes que vão entrar.
Sim.
Tinha-me dito os nomes, mas eu não me recordo.
Eu mando-te. Queres que eu te mande por mail o programa?
Não é preciso. Basta mandar-me agora aqui pelo chat em mensagem privada.
Então, espera. Chat, onde é que está? Chat. E como é que eu sei que é mensagem privada?
Onde diz para, seleciona só o meu nome.
Carrego no chat?
Sim.
Chat. E pronto. E não está. Espera agora.
E agora tem a opção do para.
Aonde?
Em vez de ser para todos.
Sim, espera.
Coloco só o meu nome.
Então, põe o teu nome.
Neste caso é ISBE.
Aqui
é
está. ISBE Cochrane Pessoal, certo? É só isto. Tu ISBE Cochrane Privately. Ok.
Sim.
Então vou-te escrever aqui. Onde é que eu escrevo isto? Está aqui, está aqui. Mina.
Ok.
John Anderson.
Essa palestrante já está cá, já está ligada. Eu vou-lhe dar co-host a ela também.
Ok.
Para ela poder partilhar e para ficar no topo da lista de participantes.
Posso sair do chat?
Pode.
Ok.
Eu já vi os dois nomes. Assim que entrar o outro palestrante, eu dou-lhe também co-host e eles depois já ficam no topo da lista.
Como é que eu close? Ok. Pronto. Ok, já está. Ok, pronto. Está ótimo. Estou a ouvir muito bem. 30, estão a subir, Cristina Lopes, André Bandeira, Isabel.
Eu estou a ver que a Susana. Eu estou a ver que a Susana.
Como é que eu mudo o meu nome? Remove, report.
Rename. Na lista de participantes pode fazer rename.
Espera. Está aqui. Vamos lá. Rename. É só para tirar o Cândido. Porquê é que isto não fica quando eu tiro o Cândido uma vez?
Porque deve ter por defeito no seu Zoom, por defeito, a opção de guardar para todas as reuniões. E então vai
Como é que eu saio dos participantes? Só agora vai clicar, é isso?
Não percebi, professor.
Já está. Posso falar com a Mina?
Pode.
Hi, Mina.
Hi, Antonio.
Nice to see you.
Nice to see you. How are you?
Lisa, thank you very much. I need to talk to you in the end. So
Okay.
if you get 5 more extra minutes, I'll ask the people who just let us both speak to each other without anybody else listening. Okay? Is that okay?
Absolutely.
We have so far 280 people registered. Okay.
Oh, that's amazing.
Because I don't know how many people show up, but I'm expecting a fair number of them to show up. So this was really, really nice. Thank you so much, Mina. I really appreciate it.
Thank you so much for the invitation.
Yeah, we are welcome. Okay, so let's just wait a little longer. Vejo que o Sr. Bastonário já está connosco. Está mute, Sr. Bastonário, está mute. Ainda não consigo ouvir.
Estava aqui a dar indicações para um ofício para a Sra. Ministra da Saúde e, portanto, ia ser público.
Muito bem. Tudo bem, muito obrigado. A gente vai começar dentro de um minuto.
Olha, estava a ouvir aqui a música dos Deep Purple chamada Smoke on the Water.
Oh, isso é um grande clássico, isso é um grande clássico, isso é um grande clássico.
Um clássico, clássico.
Isso é um grande clássico. Bom, eu vou
Muito
dizer...
bem.
Muito boa tarde.
Olá, viva, viva, professor Fausto Pinto.
Olá,
Não
querido.
está fácil. Temos
Caríssimo
que
bastonário.
ativar a nossa parceria para ver se melhoramos isto melhor, um bocadinho, não é?
Temos reunião um dia destes, não é? A plataforma.
Acho que sim, acho que sim.
Muito
Muito
bem.
bem. Professor Vasco Carneiro,
Eu vou fazer uma breve introdução.
diga-me só como é que vai ser, só para eu perceber. Aqui na.
Simples. Eu faço o welcome, explico que há três instituições diferentes estão a organizar este webinar e depois cada um deles começa a passar a palavra à Ana Paula Martins como
Muito bem.
Presidente do ISBE, depois passo-lhe a si como Presidente da Ordem dos Médicos e depois termino eu como o diretor da Cochrane, portanto, e depois imediatamente passamos a palavra aos preletores.
Está perfeito.
Uma coisa breve, uma coisa de 10 minutos, os três 10
A
minutos.
única coisa que lhe está a faltar neste momento é a professora Ana Paula Martins, não é? Ou não?
Pois é, mas eu não sei onde é que ela... Ainda agora estive com ela num outro webinar, não sei. Liga para a Ana Paula Martins.
Olha, eu depois não vou pôr mais internet.
Não, é preciso...
Ficar sem internet.
Está sem internet?
Não, está a ficar curta a rede. Vou aqui meter uma ajuda, que é o que eu agora já me habituei a isto. A rede de casa está fraca.
Professor Vasco Carneiro.
Sim.
Pronto, era só para lhe dizer, não sei se está a ver os participantes, porque o professor Olga Schulman também já entrou.
Está bem, ok. Onde é que ele está?
Também já está na listagem como anfitrião, portanto, na listagem dos participantes está logo no topo.
Diz-me uma coisa, Rui, neste momento, quem é que nos pode ouvir neste momento?
Quem nos pode ouvir? Toda a gente.
Toda a gente, ok. Estamos a falar em português, deve haver aqui vários estrangeiros, mas...
O professor Schulman ainda não tem o microfone dele ligado. Nem sequer está a reconhecer o microfone dele ainda.
Então,
ele deve estar ainda no procedimento de ingresso. Ainda não ativou o microfone.
Ok. Então pronto, vamos começar. Podemos começar, Rui?
Quando quiser, professor.
Ainda só estão 50 pessoas.
Mais
72.
Mais 3 minutos para aguardar que a professora Ana Paula Martins venha.
Estão 72 participantes neste momento. Ana Paula Martins está a entrar agora.
Ok, I will also join with a second account to present if you could let me know. O professor Oliver está a dizer qualquer coisa, vê lá o... Convinha-me... Professora Ana Paula, está na reunião?
Olá, Sr. Professor.
Ótimo, pronto.
Hoje estou com imensa dificuldade a entrar. Muito boa tarde a todos e a todas. Obrigada.
Eu vou já então começar, se estiver de acordo, ok?
Faz favor, Sr. Professor.
Já estamos só à sua espera. Muito bem. Ok, mais 2 minutos, pronto. Quem não chega a horas, a gente...
Esta é a vantagem do webinar, ó Tito, é começar a horas, pá.
Pois, não, só mais 2 minutos, pá. Mais um minuto só, que é para que eu tenho... também são 5 minutos. Eu calculei uma latência, uma latência, não há problemas.
Boa tarde a todos.
Muito bem.
Não sei se me ouvem.
Sim, senhor. Doutor Luís Abrantes, como está?
Muito obrigado. Peço desculpa que isto estava em mute e eu depois é que...
Não, tudo bem, tudo bem. Rui, podemos então agora começar. Eu propunha que pusesse toda a gente em mute e eu pudesse, exceto as pessoas que vão falar, está bem? Rui?
Sim, professor.
Podemos começar?
Quando quiseres, a gravação já está, nós já temos a sessão em gravação. Está a transmitir live para o YouTube também, okay. no link da Faculdade de Medicina que eu tinha partilhado.
Queres pôr as pessoas todas em mute para não haver interferência e depois damos a palavra aos
todas as pessoas que entram automaticamente em mute. Elas têm que fazer em mute para poder falar. Eu vou voltar a fazer mute a quem não está e agora acho que só o professor é que está com o áudio ligado e eu vou
então, pronto, muito bem.
colocar
então,
mute também.
Posso começar?
Sim, professor, pode.
Muito bem. Muito boa tarde a todos. Começo por agradecer a vossa presença neste webinar e, dado que temos quer os nossos preletores, quer muitas outras pessoas estrangeiras, eu iria passar e mudar rapidamente para o inglês. Good afternoon, good morning or good night to everybody. First of all, thank you for attending our webinar. My name is António Vaz Carneiro. I'm one of the organizers of this webinar. I'm a professor at the University of Lisbon School of Medicine, and I'm very happy to be able to participate in this event. This is an event that was organized by three institutions in Portugal. First of all, the Institute for Evidence-Based Healthcare, the second one, Cochrane Portugal, and the third one, Choosing Wisely Portugal. We have sent you the program, but I would like to have just a quick introduction, and I will now pass the microphone to the head of the president of the Institute for Evidence-Based Healthcare, Professor Ana Paula Martins.
Hi, everyone. Thank you so much, Professor António Vaz Carneiro, for handing me the words. It's just to welcome you all. I will not go for a very tough and intense introductory remarks, because I think that everyone wants to hear and to have opportunity to hear our speakers, and to have the opportunity to debate some issues that will come through the speeches. But one major, I think, item that I myself and Professor António Vaz Carneiro, and I would say all the people involved on the board of the ISBE, we would like very much to I would say, assuming the commitment with the scientific community, that we will go intensively through this pathway of getting together people from different scientific communities, different expertises from different parts of the world, jointly together nowadays much more easily in terms of these digital platforms, but of course not being far emotionally speaking, but being together for the good of science and for the good of our people and our patients. So I also welcome very deeply all the colleagues here that are representatives of the patients' associations that are I would say driving this journey with us at ISBE, and has been a tremendous pleasure and an incredible experience during the pandemic's crisis to have all this knowledge together, and everyone, I would say, fighting the same war, fighting for the humanity and for the sake of the citizens. Thank you very much. And I'm looking forward to hear everyone, not only the speakers, but also the debate that will assist today.
Thank you, Professor Ana Paula. I will now pass the microphone to Dr. Miguel Guimarães. He is the president of the Portuguese Medical Association, in which the program Choosing Wisely Portugal is settled. He has been a major force in our country to discuss precisely the topic of today's webinar, and I'll justify and I'll talk about that in a minute. So I just want to say how grateful I am to the support of the Medical Association for this specific program. And now I would like to ask Dr. Miguel Guimarães to address us. Thank you very much, Miguel.
Thank you very much, Professor Vaz Carneiro, Head of Cochrane Portugal and the Scientific Council of the Institute for Evidence-Based Health. Thank you. Dear Professor Fausto Pinto, Director of Faculty of Medicine of the University of Lisbon, my dear friend, Professor Ana Paula Martins, President of the Portuguese Pharmaceutical Association, dear all. It is a great pleasure for me to be here in this webinar organized by my dear friend, Professor Vasco Carneiro. Overdiagnosis and low-value healthcare is the theme that you have chosen for this edition, and it is crucial to improve the discussion on important things apart from the pandemic situation we are fighting at the moment. The coronavirus pandemic has spread around the globe with unprecedented consequences for the health of millions of people. It represents a challenge for many sectors. We are dealing with new incidents being reported every day. However, it is essential for the future of our health system to maintain a long-term perspective on other issues such as overdiagnosis and low-value healthcare. We must ensure that patients get all the care they need and none that they do not. In healthcare, more is not always better. Unnecessary or ineffective procedures, tests, scans, and medications cause substantial physical harm to patients and waste money and resources. Medicine is depending more and more on procedures, and for us, this has an intimate relation with the lack of time from doctors, with a negative impact in the relationship with patients. To avoid that, the Portuguese Medical Association defends that we can avoid overdiagnosis and low-value healthcare by revitalizing time and working conditions. We need all of you to achieve this goal. I also like to highlight in this context the relevance of Choosing Wisely program. We strongly defend that promoting conversations between patients and clinicians and providing scientific information is the only way to get better results in healthcare. Therefore, I will take this moment to congratulate Professor Carneiro and his team, his magnificent team, for the work developed in Choosing Wisely Portugal with dozens of published recommendations. I hope that you enjoyed the webinar. Thank you very much for all and good webinar. Thank you.
Thank you, Dr. Miguel Guimarães. As you know, two of our institutions are based on the University of Lisbon School of Medicine, and we have the director here, Professor Fausto Pinto, which of course I say hello. And this setting is not chosen by us. We thought that this would be the ideal setting to think about evidence, high-quality evidence producing. And when we thought of building this webinar, the great question was, what kind of topic would be important enough for these three institutions to be able to organize together the webinar? And of course, it came immediately to mind the overdiagnosis and low-value healthcare. This is certainly a topic that is transversal to all of our worries. And specifically with this pandemic, we will have to make very difficult and complex choices in the future. And so reflecting on this need of diminishing low-value healthcare in a time in which certainly resources for health will be less than ideal, we felt that this would be very useful to discuss with you and so that we could reflect on the new world that is expecting us. Now, to do this, I have, of course, the advantage of being friends with two people that are top-notch worldwide, and I kind of, this one advantages of having these things by Zoom. We can have top people; they don't have to come to us, although we love to have us among us. It's much easier. So not everything is bad. So we chose two prolactis, two speakers that each one of them in their own field are really outstanding. And I will present them in sequence. The idea would be that each speaker will have 30 minutes to give his or her presentation, and then we have about 15 minutes for question and answers. And then without any interval, the second speaker will go right immediately to their talk, to his talk, and then we have also 15 more minutes for question and answers. So we'll have the question and answers right after the individual presentations, if that's okay with you guys. It is my pleasure to present to you Dr. Mina Johansson, a good friend from the Cochrane world. She's a clinical active general practitioner in Sweden, and she's director of Cochrane Sustainable Healthcare, which is a new area in Cochrane. It's a new area in Cochrane that is precisely looking at this from a low value-based healthcare. She's also a senior researcher at Cochrane Sweden, and I couldn't think of anyone so appropriately interested in these areas than Mina. So Mina, thank you so much for accepting our invitation. It's an honor, but it's also a very big pleasure to have you here among us. And certainly I expect that next time we'll have a table with food and Portuguese wine to compensate you for this. I'm still hoping, I was still hoping that somebody gonna find a way through the internet we can wine. You see what I mean? I'm not forgetful that I'm hoping that I can send some Portuguese food to the internet. Mina, thank you so much. The floor is yours.
Thank you so much for inviting me here. It's a pleasure to be here. And I'm also so sorry for missing the Portuguese wine. It's very gray and in Sweden and rainy. So I would have loved to come to Portugal. So I'm going to share my screen now, right? Yes.
Yeah.
Yeah, so I'm going to talk about Cochrane Sustainable Healthcare, which is a new Cochrane field that in short is an international collaboration to tackle harms from medical excess. And as you said, Antonio, I'm a general practitioner working half-time clinically in a small town on the Swedish west coast and half-time with research within Cochrane Sustainable Healthcare and Cochrane Sweden. There. Cochrane Sustainable Healthcare was launched in December 2019 and is supported by a large group of amazing people around the world with a very diverse range of expertise and perspectives. I'm the director and Dina Muscat-Meng from Copenhagen is the coordinator. Some background, which I think most of you are already familiar with, but costs of healthcare has risen sharply in most high-income countries during the recent decades, and the same development is seen in middle-income countries. There are many reasons to this. One of them is that a considerable proportion of what we do in healthcare is waste or low-value care. Exactly how to define low-value care is, of course, very complex, but studies have estimated that between 20 to 40% of what we do in healthcare is low-value care. This is problematic from an individual perspective because unnecessary medical intervention can cause serious harm to people. And it's also problematic from a community perspective because low-value care has opportunity costs and consume resources that could be spent on high-value care or on societal interventions, like, for example, a well-functioning education system or social welfare, which can sometimes have a much greater effect on public health than interventions within healthcare. So by tackling the crisis of medical excess, we can reduce harms for the individual and prevent waste and make our health system and societies more sustainable. But how can this be done? I believe that one problem is that medical science is focused on medical progress, all the way from the research questions we pose, to the methods we use, to the production of evidence synthesis and guidelines. It is all done from the perspective of potential beneficial effects of medical interventions, which is, of course, good. But in order to build sustainable health systems, I think we need to adapt those processes to also fit with the notion that medical interventions can cause harm. An example. It is commonly believed that the introduction of CT scans to diagnose pulmonary emboly was a great improvement. CT has a much higher sensitivity and is less invasive than the previously used test, angiography. In this study, trends in incidence and mortality from pulmonary emboly in the US were analyzed. So you can see CT scans to diagnose pulmonary emboli was introduced around here. And this was followed by a doubling of incidence while mortality remained virtually stable. There are two possible explanations to this pattern. Either there is a true increase in incidence of pulmonary emboli due to increase in some risk factor, and a simultaneous improvement in treatment, keeping mortality at a stable rate. The problem with this explanation is that the improvement in treatment would have to exactly and simultaneously equal out the increase in incidence through an extended time period. It can't be too fast, because then mortality would initially decrease. And it cannot be too slow, because then mortality would initially increase. So therefore, this explanation is quite unlikely. The other possible explanation, which in my opinion is far more likely, is that the increased sensitivity of CT scans makes us find pulmonary embolies that does not need to be found, because they would never have caused symptoms, even if they remained undetected. This would also mean that the increased sensitivity does not seem to have a substantial effects on the pulmonary embolies that would lead to death, since mortality has not decreased. And of course, complications due to anticoagulantia rises with the incidence. This same pattern can be recognized in many areas within medicine. This is another example, screening for thyroid cancer. Screening for thyroid cancer was introduced in South Korea at the turn of the century and was followed by a sharp increase in incidence while mortality remained stable. You can almost not see mortality, but it's down here. Screening has actually been successfully de-implemented after this study, and the incidence is decreasing while there are still no changes in mortality. And again, this pattern with a sharply increase in incidence and a stable mortality indicates that screening finds thyroid cancer that does not need to be found, and that screening does not seem to have a substantial effect in improving prognosis for patients with thyroid cancer that would have led to death. And again, this pattern can be seen in many areas within medicine, for example, also for malignant melanoma and kidney cancer. This is a study based on a population in a geographical region in Norway. So in this region, basically all common tests that you can imagine have been taken on all adults and collected in a database. The authors of this paper applied the evidence-based European guidelines on hypertension to this database, to the population, and found that more than 80% of Norwegians older than 20 years were in need of medical attention for their cardiovascular risk, which means that they should see their GP, and if lifestyle advice did not work, pills should be considered. Interestingly, only 3.9%, the green up here, had a normal cardiovascular disease risk, according to the guidelines. Everyone else had an increased risk, which sort of puts the concept of normality into question. And it's perhaps even more absurd considering that this is one of the healthiest and most long-living populations in the world. If these evidence-based guidelines would be followed, 99 GPs per 100,000 adults would be needed to handle hypertension only. The problem is that in this region, there is only 87 GPs per 100,000 adults. So this means that if the guidelines were followed, the healthcare system would crash. No GP would have time to take care of anything else than hypertension. I really want to stress that I am not saying that hypertension should not be diagnosed or treated. That's indeed a very important part of my work as a GP. But I think this example shows that the processes for primary research, evidence synthesis, and guideline development are currently not very good at considering resource use and opportunity costs. or at helping policymakers, patients, and clinicians to prioritize between different medical interventions. It could, of course, be argued that the reason for this massive mismatch in what is recommended and in guidelines and the available resources to implement the recommendations are due to poor guidelines. And there are many important initiatives that help guideline panels to better consider resource issues. For example, the evidence to decision framework, which I think is a major step forward in terms of considering medical access and resource use in guidelines. I think Holger will talk about this later. However, I still think there's some way to go. How have we ended up in this situation? There are many contributing factors, of course, and vested interests is I think, one of them. This study looked at guideline panels who decide on cutoffs for diseases, like, for example, diabetes, hypertension, and asthma. As you probably know, most cutoffs for diseases and risk factors have been gradually lowered during the last decades. And because of the distribution in the population, a rather small lowering of the cutoff for diagnosis could easily double the percentage of people defined as having a disease, or at least increase it very much. In this study, the authors found that 10 of 16 guideline panels lowered the cutoff for the disease with no consideration of potential harms in terms of overdiagnosis and overtreatment. 75% of the experts had financial ties to a median of 7 pharmaceutical companies. And in the case of asthma, 23 of 24 experts were paid by a median of 6 companies. I was myself a while ago invited to give a talk at an event organized by a pharma company, and I was offered more than 100 euros per minute of my talk. So I concluded that I could quite easily double my monthly salary by talking at such events. Yeah, I declined, but yeah. So I would argue that the way that primary research, evidence synthesis, guidelines, and health systems policies are organized today leaves many of my patients, as well as me as a practicing GP, feeling like this, overwhelmed by a tsunami. This picture is from a paper in the BMJ on the importance to include aspects of treatment burden for the patient in guidelines. I think it's very illustrated. Yeah, it illustrates very well the fact that we have been very poor at including the outcomes that are important to patients in research and policymaking. So, as you said in the beginning, I think we can all agree that more is not always better, but it can sometimes be very tricky to know when it's too much. It is increasingly recognized that medical excess threatens the health of individuals and the sustainability of our health system. The situation is urgent and novel approaches are needed to tackle these issues. Because the way we do it today, the screw does not seem to fit the screw nut. The goal of Cochrane Sustainable Healthcare is to enhance the relevance of primary research and evidence synthesis to tackle medical excess, and to increase the use of relevant evidence to enable sustainable healthcare. Our priority areas are to develop fundamental reforms to evidence production and synthesis so that research on medical diagnosis and intervention address both benefits and harms. To push for a broad consideration of resource use at all steps in the evidence chain, to promote a more sensible prioritization of resources, both in terms of financial and human resources for societies, as well as of treatment burden for the individual patients. It's quite ambitious. And further, to contribute to research of how de-implementation and de-intensification is best done without causing harms to patients, deprofessionalization, or counteracting shared decision-making. And finally, to elaborate and promote innovative methods for communications with patients and the general public about medical access. Unfortunately, the work with Cochrane Sustainable Healthcare has been frustratingly slow since the launch in December. This is primarily because I have had to work more or less full-time clinically due to the pandemic, and I've also been ill myself. But we have started some very interesting projects, which I think have great potential. Just very briefly, some of the projects that we are working on. We are evaluating disease awareness campaigns and their potential to push overdiagnosis and overtreatment. And this work is commissioned by the WHO. We are working on a suite of projects aiming at reforming processes for evidence synthesis and guideline production to consider medical access and harms of medical access. Also a very ambitious aim. We have been involved in a rapid review on utilization of healthcare during the pandemic, led by Ray Moynihan at the Bond University. And we are exploring the possibility to take this work further. We did a systematic review of all Cochrane reviews of screening interventions and found that the majority of them did not address even the major harms of screening. This work is just recently published, and based on this, we have had very constructive discussions and feedback from Cochrane editors, which has resulted in that we are developing resources for authors of systematic reviews of screening. We are also discussing the possibility of developing reporting guidelines and core outcome sets for screening interventions. We are working on knowledge translation projects in regards to available Cochrane evidence relevant to de-implementation and de-prescribing. One problem is that some review questions that are relevant to sustainable healthcare fits poorly into the framework of Cochrane review groups. And we have done some work to improve this. So if you have an idea for a Cochrane review that you think is relevant to sustainable healthcare, but you have problem finding the right review group, you're very welcome to contact us, and we can see if we can help in any way. And finally, we are very keen on developing collaboration with important stakeholders, like, for example, Choosing Wisely. I attended the meeting in Berlin last year, and I will attend the Choosing Wisely seminars tomorrow and the day after tomorrow. And I think we have had very productive conversations and plans for future collaboration with Choosing Wisely. So I hope when the pandemic calms down a little bit that we will have time to develop that. In conclusion, we need an evidence base better suited to support sustainable decisions about healthcare. Novel approaches and methods are needed with a focus on tackling medical access at all points in the evidence chain. And our aim is to develop a global network for collaboration on activities ranging from short-term research projects to longer-term reform initiatives. Lastly, like you said in the beginning, the pandemic has further increased the urgency to deal with waste and low-value care because the resources spent on COVID, as well as the global economic crisis, means less resources for non-COVID healthcare. It is more essential than ever that we use those scarce resources wisely. Also, the rapid decrease in the use of medical interventions during the pandemic has obviously caused a lot of harm. The focus on COVID has had considerable opportunity costs for non-COVID disease. And I've seen many direct examples of patients getting harmed from this in my clinic. However, I believe that this pandemic and the very rapid drop in utilization of medical interventions offers an opportunity to evaluate which interventions and for which patients that may cause more harm than good. It's like a natural experiment. And I also believe that the pandemic constitutes a momentum to tackle issues of medical access and low-value care. Policymakers, the public, patients, and clinicians, I believe, have never been more open to consider the harms of medical interventions than now. And if anyone is interested in discussing and how to take this further with us, please contact us. Thank you very much for listening. Did I stick to my time?
Thank you, Mina. Thank you so much. Really appreciate. Great presentation. Now, before we have a few minutes to pose questions, to ask questions to Dr. Johansson, but giving my privilege of being the moderator here, let me just ask you two quick questions. First, you already mentioned that one of the challenges of this series is of course how to define low value based healthcare. Okay, so do you have any methodology, or do you see any new field of knowledge that can consistently to help us out, or to define what you should tackle in this area?
I think that's a huge question. I think it takes a lot of different initiatives to handle that very well. I mean, to start with, on very many medical interventions, we have research on the benefits, but we don't have research on the harms.
Mm-hmm.
We don't have research on the very tangible harms, like complications from surgery and stuff like that. But we also don't have research on the more difficult to measure harms, like many patient relevant outcomes that are more difficult to measure. So to be able to judge whether an intervention is low value care or problematic, you must know both the benefits and the harms. So that, I think, is the first challenge, that we need much more research that also looks at the harms. And also then the evidence synthesis and the guidelines also need to consider those harms and including the more difficult to measure harms. Then I think the next challenge is that, like I showed with the example of hypertension, I think that one of the problems now is that we consider each medical intervention in silos. So, and even we do cost effectiveness analysis and stuff like that, but we lack a proper system to do horizontal prioritization. So this means that like when we have an intervention where you have a benefit, it seems like it's almost always recommended without really considering the consequences in terms of human and financial resources, both within healthcare and in the society at large. I mean, I know that we have some systems for thinking about horizontal prioritization, but I think that's really an area where we need to develop substantially in order to get this together. Because what's happening now, at least in my clinic as a GP, is that the guidelines and the policymakers doesn't really help us prioritize. And the recommendations are so extremely much more than we have the resources to do, the human resources. And this is in a high resource setting like Sweden. So we don't have any possibility to fulfill all the recommendations. So what are we doing? There's no sort of structure around that. It's arbitrary. It's the patients that have the most resources to seek our help, I think, and that is a problem with equity. So I think there are many ways to that, but I think one way is to make a definition. One part of it is to make a definition of low value care, but I think it also needs to do a lot of work on the evidence base and what kind of evidence we consider to be able to make judgments about that.
Yeah, thank you. Yeah, I also think so. Quick second question. One of the things that I'm kind of curious in the future, trying to figure out with the new world that we inherit with this pandemic, in which, of course, most, if not all, healthcare systems will be under a certain constraint in terms of resources. If we could look at this as an opportunity to change the way that we look and the way that we classify good practice. You know, there are plenty of people that believe the good practice is a very aggressive practice, or that is a very expensive practice, or that only uses the latest of the innovation. There's a lot of people thinking that's the the gold standard of a good practice. Now, we don't think so. We experts on this area don't think so, and that's really a problem. I know Don Barrow is going to talk about this tomorrow in our meeting on choosing wisely, but do you see any opportunity in a world post-pandemic of implementing this approach, Mina?
Yes,
and I know the question is difficult. I know the question is very difficult, but just give me a short answer what you think.
It's the difficult questions that are most important. I see a huge opportunity in this. It's a huge momentum, I think. And I first want to say that, I mean, I've really seen the bad sides of the pandemic close hand. So this is definitely a tragedy. This pandemic is, of course, a tragedy. But I think when we talk about sort of the benefits of it, we've seen it's very difficult to de-implement stuff. We are not keen on stop doing stuff. But suddenly, like from one day to another, we have stopped doing so many of the interventions that we already knew were waste. And how could that happen? I think it's because everyone has become much more aware that medical interventions can cause harm. Like now, if you go to the hospital and do an X-ray, people are worried that they will get COVID. So they are aware that this intervention can cause harm, and previously they were not. Of course, it could cause harm before too, but they were not aware of it. So I think it's a major culture change that has changed from almost one day to another. And I definitely think there's momentum to work with these issues. I think it would be great to have these more international collaborations across organizations that are interested in these questions to really try to push this agenda forward.
Okay, thank you. Now I'm going to pass the word to our audience. Please either raise your hand if I can see it, or at least purely and simply just go in and ask your question.
I have a question.
Please. I'm sorry, I don't have a very good way of managing this. Please, by all means, just
Okay. Dr. Johansson, my name is Peter Villax. I'm one of the few here that is not a practitioner. I found your presentation very inspiring. There are two things I'd like to talk about. The unneeded guidelines. I am very happy that you're able to start identifying the undue influence that industry has on these panels and making guidelines tougher every year, which of course increases the size of the market. And I'm very happy, and even as a representative of industry, that you've begun to flag this situation, particularly in the asthma panels where 23 out of 24 are paid by industry and maybe up to 100 euros a minute. I think it's fantastic that you're able to identify that. There's another topic that made me uncomfortable, and that was your sense. So in terms of unneeded guidelines, I think you're in the right direction. But then you went into unneeded diagnosis. And there's a sentence that I wrote down: embolies are found that should not be found. And your statement made me very uncomfortable, because as a person that develops drugs, as a person that develops medical devices, we're always trying to do better. So how this, for me, this was a new reality. I know what you mean, but how are you going to tell decision makers, regulators, and industry that we should not be developing machines that are so precise? I see your point, but I don't know how to respond to it in practical terms.
I mean, I think you're absolutely right. And when it comes down to me practicing as a GP, sometimes I can have the knowledge about this, but still it's very, very difficult to not know more. Maybe that's also just human. We want to have the most sensitive stuff. We want to really do the tests and know more. But I think, if you think about it, I think this is something that is very difficult to handle at sort of the individual level. But if we think about research on tests, on diagnostics, there's too little research on the effects of diagnostics, I think. And the research is very often on test performance, like sensitivity and specificity. But what we want to know, sensitivity misses problems with. Do you hear the sound? Okay, now it's better. So, what we would like to do is to have more randomized trials where people are randomized to one test and the other, and then you look at patient relevant outcomes of that test. Like, for example, that's done in radiology of low back pain. Then people were randomized to have an X-ray and to not have an X-ray, and then they looked at clinical outcomes after a while. I think that kind of studies, captures overdiagnosis. It could capture overdiagnosis and the clinical benefit of the tests. So I understand that that's very difficult and it costs a lot of money and it's problematic from many aspects, but I think this is also problematic from many aspects. And again, I'm not saying that CT scans shouldn't be used to diagnose pulmonary embolies. With this example, I more want to show that the things we take for granted today may not be true, and that we need different kind of research to actually know that what we're doing is more beneficial than harmful.
Thank you, Mina. I have a question on the chat from Professor Cristina Ribeiro. Dear Mina, I would like to know more about the innovative methods of communicating concerning this subject. I'm assuming that she's communicating to the general public, to the consumer.
Yeah, I wish I had a good answer to that. I mean, I think that's one of our priority areas, but we have not really started any good projects on that. We are evaluating the disease awareness campaigns now, and I think we learn a lot from it there. But it's not. I mean, what I'm trying to do with this field is trying to gain momentum and find synergies between different working groups or different people that are working with this already. And that area is not personally my area of expertise. But do you have any suggestions? The person who asks this. I mean, it's extremely difficult to. Yes, sorry.
Christina?
Thank you very much, dear Mina. I think this is a very huge, important question concerning the best communication when we are talking about this when we are talking about the best information to our patients. Myself, I'm a general practitioner too, and all the agenda that we have in our care should be very targeted to the patient. And the way that our work will be the better and the best for the quality of life of those patients. And that this is an important aspect, and this is mostly a priority for all of us, all practitioners. But concerning research, I'm really very interested to know which will be the best trigger to have the innovative methods to target this important subject. Thank you.
Yeah, I fully agree. I think it's the communication part is extremely important and takes more thinking on that. I agree fully with your comment.
Thank you, Mina. Thank you, Professor Cristina. Anyone else wants to put a question or comment?
May I just have a short comment?
Sure.
Challenge a little bit. That was a very nice presentation, and this is Fausto Pinto. I'm a cardiologist. I'm also the dean of the medical school, and very much involved with a lot of issues related with cardiovascular disease. So my challenge to you is what really worries me and worries let's say, the medical community as a whole, is of course to keep this balance between undue procedures or overdiagnosis, as you mentioned, but actually is quite the opposite, because we have nowadays treatment strategies, diagnostic strategies that are very well designed and very well proved. And by the way, there have been, over the last few years, a lot of studies, a lot of using imaging. If people wouldn't mind to mute the microphones, otherwise it's a lot of noise if they're not speaking. A lot of imaging studies that actually currently they included in the guidelines with a level of recommendation, which is quite high compared with what it was just a few years ago. So there's building up a lot of data now with different imaging modalities, and that's why there were developed also appropriateness criteria for the recommendation of certain diagnostic studies. But I don't want to make this too long. But my common question is, okay, this is of course very important, and I think that's part of the medical field. Basically, to be able to recognize the situations where you really have to make sure that you're doing the best to have the right diagnosis and use appropriately all the different technologies that we have. But we should keep in mind that the advances that we've witnessed, and particularly in the cardiovascular field, we know today that 80% of the increase in lifespan over the last 30 years were due to the advances in the cardiovascular field, not only in terms of new medication, new devices, not so good at prevention, as we know. So we've been very good at treating, not so good at preventing. So one of the challenges is actually how we're going to keep this balance, but keeping in mind that all the advances that we've witnessed, they had a major impact in patient outcome and lifespan. And the problem now is actually how can we, and that's actually one of the worries of the WHO as well, as you know, is how can we actually use even simple strategies. For instance, for hypertension, you mentioned hypertension. More than 2/3 of the world population with hypertension is not even we have the 1/3 rule. 1/3 of people with hypertension, they don't know they have hypertension. Actually, only 1/3 is recognized. Of the 1/3 recognized, only 1/3 is treated, and only 1/3 of the treated is controlled. And we have simple drugs to manage hypertension. So I would say, and it's a little bit provocative, that our main challenge is, of course, to keep this balance, but the main challenge is actually how we can provide appropriate medical care, particularly in the regions where there's not much. And what I'm worried is that this message, which is very relevant, particularly in wealthy countries, if we look at the world as a whole, actually the problem is quite the opposite. Is the majority of the global population has not access to what is proven today that can improve morbidity and reduce morbidity and mortality. Just a little bit challenging your concepts, which are totally correct, but I think we need to think also, the other side of the coin.
Yeah. Thank you so much for that comment. I fully agree with you. I mean, for me as a GP, in my clinical work, the motivation, the rationale for me to stop doing low value care, it's absolutely to have the human resources, to have the time and the resources to give high value care to the patients that will have benefit from the interventions. So, and I mean, I think when you talk about low income countries, there's definitely a huge problem with too much medicine in low-income countries also, because we can see that the resources are not used in a reasonable way. So it's much resources are spent on low-value care in many low and middle-income countries too. So I think the less resources you have, even the more important that you use them wisely. And I think, I mean, so from my agenda, the major aim with reducing low value care is to increase high value care. So I don't think that it's like, it's not a clash between those two things. It fits really good together, I think. And what's the other, there was something more I'm gonna say, I forgot now.
Oh, you answered the question. You answered the question, Mina. I have a question here from a patient. It says here, dear Mina, many patients feel as overburden of medication and scans, tests, and diagnoses, especially older patients with multiple comorbidities. Do you think that having a patient manager would be beneficial? This comes from a multiple sclerosis association. A
patient manager?
Yes.
that person would help the patients at a specific center to guide them through the processes or stuff like that. Is that the role of the patient manager?
Yeah, I'm assuming that, but the question is that if you agree with this concept.
I think there's I don't know exactly what a patient manager does or the role of that, but I think, it's so hugely important to improve the patient perspective in medicine and what we do in medicine, I think, and it's just strange that you even need to sort of say that, but I think it's just clear that all the way from the research question to what we do in the clinical encounter, the patient is secondhand in many times, and it should absolutely not be like that. It should be the other way around. And I fully, like, multimorbidity is just one other example of that. The screw does not fit the screw nut. That what we do in medicine is not adapted to people with multimorbidity, even though a large proportion of our patients have multimorbidity. And I think, maybe it's very good with the initiative with the patient manager, but I think it's quite telling that is even needed. Shouldn't we, as a healthcare, take care of our patients as individuals and care for the need that they have? Should we add so much problem to them that they need a manager to help figure out how we help them? I think that's somehow, I'm not saying that it's a bad idea. Perhaps it's a very good idea, but I just think it's telling that we are not doing a very good job at the moment, unfortunately.
One of the ways that I think captures this discussion, so that we don't come out of it thinking that you are proposing or we are proposing that we don't treat patients. It's that studies that look into the change of this disease definition or risk factors definition in America. When the American Cardiology Association decided to lower the limits of blood pressure to be treated from 150/90 to 125 or 130, can't remember, 80, overnight appeared 20 million new hypertensives. When the American Society of Endocrinology and Diabetes decided to lower the fasting blood sugar from 128 to 117, I can't remember the numbers around this, overnight 15 million more people were classified as having diabetes. And that's what we are talking about. Yes. Nobody's saying that we shouldn't treat them. Nobody's saying that it's not worthwhile to look at this. We are just saying, as you aptly put it, are we doing more harm than good? And this issue, I think, and I'd like to hear your opinions, is probably the major issue that we should look at. Are we doing more harm than good?
Yes, it's like I said, when this picture showing the effect of hypertension, I do not in any way say that we should not treat hypertension. I think that's very, very important. It's just that we need to consider the harms and benefits for each cutoff for when we treat it in a different way, I think. But it's very easy to, when you come with this message, to be understood as a nihilist, like you don't want to do anything and you can just, do nothing and let nature has its turn. That's definitely not my agenda. And I think that comes also with the question about communication. When you try to communicate this, you get a little bit like, so it's very easy to be understood as the message, as something that it's not really is.
Thank you very much. We just got the time to, we arrive now. We really appreciate your talk. Thank you for participating in this webinar. Of course, you're invited to stay until the end. May I ask you to stop sharing your screen so we can ask Professor Holger Schoenemann to get in? I think Professor Schoenemann is already among us. Olga, are you there? Olga, are you there?
Yes, I am here.
Oh,
sorry.
Great. Now, it is my pleasure to introduce to you Professor Holger Schoenemann. He's an old friend from several areas, specifically guidelines, in which he's a world expert on, and also on the Cochrane activities. He is the professor in departments of health research methods Evidence and Impact and of Medicine at McMaster University in Canada, and is also the director of Michael de Groot Cochrane Canada Centre at McMaster Faculty of Health Sciences. Olga, I asked Olga to talk to us today about clinical practice guidelines as a tool for diminishing low value of healthcare. Olga, on behalf of all our three institutions and on myself, I would like very much to thank you for your kind willingness to talk with us today. Thank you so much. The Zoom is yours.
Thanks so much for having me. Great pleasure. And as was said before, I'd love to be there with you, not only for the wine, but my favorite fish restaurant is in Lisbon, so I miss it very much. Anyways,
thank you.
Thanks again for having me. And I just started with my disclosures before I give you a brief overview of what I'm actually going to speak about. So I will speak a lot about grade and guidelines. Obviously, I don't have any direct financial conflicts of interest. All of my conflicts are really intellectual in nature, and there's a few people who I borrowed a few slides from, or whose work is quite relevant here that I mention on this slide. But what I will do is I will take a slightly more positive spin on what we have achieved in guidelines over the last 20 years and their impact on low-value healthcare. I will start really with a perspective of what low-value healthcare from a guideline perspective is, from a recommendation perspective is. And again, I will paint a more positive picture. I think a lot of the issues that we believe need to be confronted have already been addressed, and we are still in this knowledge translation phase that makes sure that all areas of healthcare actually get to that or understand all of the efforts that have been made around, as was just mentioned, diagnostic testing and focusing on patient-important outcomes, and so on. So conceptually, things are probably there. It's probably much more about the implementation. So I'll start with that from a guideline perspective, how we determine low-value healthcare from a guideline perspective as well. And when I say guideline, what I refer to is a guideline containing many individual recommendations, okay? So a guideline, for instance, on breast cancer may have 10 or 15 recommendations. A guideline can have one single recommendation. I will talk about negative recommendations because I think it is particularly necessary in the context of low-value healthcare and talk about decision-making in healthcare. And I start with that actually, just to lay out some of the concepts that we believe are relevant in making recommendations, creating guidelines for that then inform what we should be doing or what we should stop doing. So I start with this. I heard from Antonia that many of us are physicians. So I'm a practicing internist. I do internal medicine, and I happen to be also a clinical epidemiologist. So I try to combine these two things. And most of us have heard about do no harm. And some people still, when they finish medical school and get licensed, swear the Hippocratic Oath. And the issue that we are confronting is really about doing no net harm. And I will make this concept a little bit clearer that we laid out about 10 years ago or so, because it is very much related to the issue of low-value healthcare and stopping things that we are doing. And Minna was kind enough to say, look, we're not looking at burden. We don't have good evidence oftentimes on the potential downsides, the negative outcomes. And this very much, I think, has to do with this fundamental misperception and misconception that we are thinking about doing no harm. We focus on benefits, but in reality, every decision in health, every decision in life comes with downsides. And even if it's just the burden or the time that you invest, which is equivalent to burden. So making decisions is about balancing the good things and the bad things. In health decisions, typically it's about the health benefits and the harms, and harms in our lingo include burden. However, whether or not it's all about the health benefits and the harms, and whether or not the health benefits outweigh the harms when we suggest to do something, depends on context. It depends, for instance, on where you practice. It depends on whether or not you take the perspective of a single individual or the population. For instance, around payments. For rare diseases, we oftentimes are willing to spend very large amounts of money for treatments. There's good justification to that in many instances. But if we take a population perspective, these decisions become a little bit more complicated. I said context. What I also mean by context is, for instance, is the intervention feasible or acceptable? So if we make recommendations on a global scale, not everywhere in every low or middle income country would you have access to do complicated imaging, including MRIs or even CAT scans for pulmonary emboli. At the end of the day, when we consider these issues on feasibility and acceptability, possibly the perspective, it is about balancing the consequences. So when we look at options in healthcare, we are making decisions for or against these options on the basis of consequences. And it is interesting because one of the definitions of low value healthcare, and it's an important distinction to what we are talking about in guidelines oftentimes, is that services that provide little or no benefit to patients, have potential to cause harm, incur unnecessary costs to patients, or waste limited healthcare resources. That's a pretty good definition, but it's probably not complete. And one important, very important terminology issue is about what we mean by values. When we actually speak about values in guidelines, we mean we refer to the value that people place on an outcome. And it's not the entire gestalt of values. That's quite important, and I'll get back to that issue as well. So at the end of the day, this determination of whether or not something makes sense, to use a different term, again, has to do with things like, are there benefits? How important? What value do people place on the outcome? Is it low cost? Is it doable? And we balance this with exactly the opposite: high cost, harms, burden, and whether or not something is not doable. And this evaluation, we should be very clear, takes place on some sort of continuum, right? At the end of the day, it's about the desirable consequences, not only the health effects, but the desirable consequences and the undesirable consequences. And how do we determine this? So Minna mentioned the evidence to decision frameworks. I'll explain that a little bit more during my presentation as well. But essentially, it is a set of criteria that determine whether or not, at the end of the day, an option creates more desirable consequences as opposed to undesirable consequences. That has to do with the baseline risk or the burden of disease, with the desirable effects that an option incurs, a device, or whatever the intervention is. The undesirable effects, how certain we can be in the evidence around this part. The values, and here again, I refer to values differently. It's about how important the outcomes actually are. The balance of the effects that are determined by those three factors, right? The desirable, the undesirable effects, the certainty of the evidence, and how important the outcomes are. Resources, the certainty of the evidence in what the required resources are, cost effectiveness, equity considerations, acceptability considerations, and feasibility considerations. And at the end of the day, when we have evaluated these criteria, we think that there are net desirable consequences, we say, okay, there may be a recommendation in favor. But the very important clarification for today is that a recommendation can go in both directions. And I will show you a number of examples for that. A recommendation in a guideline may say you should stop doing this. And that recommendation is equally important to any recommendation in favor. And if you actually look at how many negative recommendations or recommendations to stop doing things are in modern clinical practice guidelines, it's actually quite impressive. And that addresses some of the issues that we are talking about. So at the end, we in the low value healthcare, we typically call this the lower value kind of interventions, right? Or low value healthcare, when we are on that side of the spectrum. And desirable consequences, again, do not only have to do with health effects. And we then make recommendations pretty much along this continuum in trustworthy guidelines. So there may be strong recommendations against an intervention, such as a screening program or a costly technology that doesn't cause any measurable desirable consequences, up to the strong recommendations for an intervention. Again, this just being this balance. At the end of the day, it's not about the health effects, it's about this whole set of criteria. The next question that we ask in this context is, once we've done this evaluation, this particular, I go back 2 slides, once we've looked at these criteria, the evidence related to that for a specific health question, we ask ourselves, how sure can we be that the desirable consequences outweigh the undesirable consequences? And I refer to the evidence to decision frameworks. It's basically evidence synthesis for the criteria related to a specific question that we appraise, and then formulate recommendations or coverage decisions on. I refer to this, this is just for the interested readers or the interested part of the audience here. These evidence to decision frameworks are a product of a project that we did with the Great Working Group, an EU-funded project, the so-called DECIDE project that we ran from 2011 to 2015 with a number of big international partners. And I'll just refer quickly to this paper here, that the first of a series of 5 papers that we, some of them we published in the BMJ at that time, where we describe the actual fundamental principles of these evidence to decision frameworks that lead, again, to different types of decisions, including those for clinical practice guidelines. In clinical practice guidelines, coverage decisions. We talked about tests, so Minna talked about tests, how we combine surrogate outcomes with patient-important outcomes, and how we use these frameworks for health systems and public health decisions. Anyways, I come back to this. So these evidence, how do we balance desirable and undesirable consequences? Those of us working in the guideline space believe that guidelines are the answer for that. And guidelines are basically systematically developed evidence-based statements that assist providers, recipients, and other stakeholders to make informed decisions. Informed decisions about appropriate health interventions, either to stop them or to continue them. And they are broadly defined as clinical procedures, public health, and policy actions. And again, I emphasize, recommendations in a guideline are either for or against an option. How does this work? In our context, it often starts with a panel that needs to make a decision. They develop a healthcare question. We typically use the PICO format, population intervention comparator and outcomes. We base our decisions on outcomes that are critical or important to patients. So it addresses part of what Minna related to. We focus on outcomes that really matter and have processes in place for determining this. Core outcome sets are part of the answer, but they are not the entire answer, right? Because of the perspectives and so on that are being taken. We then do systematic reviews, such as Cochrane reviews. We look at the evidence synthesis that we typically present in a type of format that was mentioned earlier. You know, how do we communicate that? In a format that we have tested in randomized controlled trials, that seem to enhance understanding of key information, at least of health professionals. There's some work on plain language summaries that we include that focuses on consumers, where we also have done trials in order to see what ways, you know, enhance understanding of other types of consumers of health interventions. So they would be often narrative statements, but the plain language statements are in here to enhance understanding of any user. And we then utilize this information using these evidence to decision frameworks to arrive at recommendations. And I will emphasize recommendations, trustworthy recommendations, typically are made for or against an option, and we label them typically as strong or conditional. I get back to that item as well before we include a recommendation in a particular guideline. So I'll just quickly review before I get to my clinical examples, what is a good recommendation? So this is an example from guidelines that we did with the American Society of Hematology, where we basically have a formulated recommendation that would describe the patient population, the intervention. This deals with, for instance, pharmacological VTE prophylaxis in acutely or critically ill patients. And this has to do with patients who are not receiving pharmacological prophylaxis, and it's a suggestion to use mechanical prophylaxis. The guideline contains one or more recommendations that depends on the topic that is covered, and they should be described in great detail and should link to the evidence that supports it. We use, as I said, these evidence to decision frameworks that include a synthesis of the evidence. We provide the background, subgroup considerations, justifications, and any similar recommendations to actually support the judgment and enhance understanding of those who want to use it. Now, you see here, we suggest the intervention. This is something that we call a conditional recommendation, or it's the wording that we use for conditional recommendations. That is recommendations where not all stars are aligned. Think about the desirable and undesirable consequences, where we are not entirely sure for many reasons when we've worked through an evidence to decision framework, whether or not to recommend against or recommend in favor. And indeed, most recommendations are these type of conditional recommendations. So you can think of them as a yellow traffic light. I use this analogy all the time. You get to a crossing, you see a yellow traffic light. What you do with regards to going and crossing the crossing or stopping depends on the actual circumstances, right? If somebody's right behind you and you stop and you cause an accident, you might go across because you think that the benefits are greater. If that's not the case, you might stop. These type of recommendations will require much support with implementation. Other recommendations will not require a lot of thinking and a lot of support. They are straightforward. So for instance, aspirin in acute myocardial infarction. It's a strong recommendation. There's high certainty of the evidence. We consider doing this. It's a type of green light recommendation. As I said, strong recommendation, just think of it as just do it. I will focus on those recommendations that are actually here in the middle, the type of conditional recommendations to make the point. Okay. And I think it's good when I was invited to give this presentation, I thought, and listening to the first presentation, it's probably always good to go a little bit back in history and think very carefully what has already happened so that we don't repeat what others have already worked on and really catch up or take it up where science is left off and stopped, and we take it from there and then make new progress. And I will use an example that is about 8 years old simply because I do believe it exactly exemplifies what for instance, the Choosing Wisely campaign is trying to do. So my first example is on TB. Tuberculosis, it's a very, it actually, if you leave COVID-19 aside now for daily death, it's still the infectious disease killer number one. There's approximately 1.5 million deaths per year. And it is one of the top 10 causes of death, the most deadly single infectious agent, it kills more people than HIV or AIDS kills. India is the country with the biggest burden globally, accounts for a very large number of cases. And there has been a lot of progress made by, in particular, WHO, the WHO Global TB Department on altering the trends for mortality. And I'll give you an example for one intervention that I think has contributed to some degree in terms of helping with the global burden of TB, and I'll tell you why in a second. But anyways, so lots of progress has been made. We are by far not there. I'll give you an example of what has been achieved. So a few years ago, 8 years ago, WHO engaged in an effort to see whether or not serological testing for TB in particular settings like India has more benefits than harms. And one of the reasons for doing this was really that, first of all, many players knew that the serological tests did not offer what others would hope they would do. The other thing is that there were entirely implausible claims by those who produce serological tests to identify or diagnose TB, such as this particular test here that claimed 100% specificity, sensitivity and 100% specificity, which is basically impossible. But anyway, so lots of these tests on the market, and there were more than 1.5 million serological tests applied in India per year for something where we did not know whether or not it actually causes more benefits than harms. In fact, not only did it lead to diagnosis and possibly to possible stigma, in particular in young females who tested positive, it was common to test them because it was felt that a positive TB diagnosis was associated with infertility, so it caused a lot of problems. It also caused a lot of problems in terms of treatment because practitioners started treating people on the basis of a positive, for instance, test result based on these serological tests, and they used all sorts of different drug regimens that contributed to a big degree to multi-drug resistant TB. So having seen this, having reviewed the evidence, and this is why I think this is such a wonderful example, WHO actually, after the review of the evidence, made a recommendation, a strong recommendation, that these commercial tests not be used for the diagnosis of pulmonary or extrapulmonary TB. Because the evidence was simply inconsistent, imprecise, and of low certainty, coming with high proportions of false positives and false negatives that led to more people harm than people benefit. It was actually the first negative recommendation that WHO issued on TB. And so they used the grade process for doing this. I was actually the chair of that particular guideline panel. We believe that it actually made a big difference, right? But the main reason why I'm mentioning it is that big organizations like WHO long recognized that these negative recommendations to stop doing things make a big difference. And I will just go here. We believe that there is actually a big difference because what happened were big media campaigns and subsequent evaluations. Was the problem completely eliminated? No, I won't go into this. There's lots of reasons for why it was not completely eliminated, but some progress was made that hopefully contributed to the NTB strategy and the results. I will give you a second example fairly quickly. Second example, I like to use my own examples because then at least I know reasonably well what I'm talking about. This is from the European Breast Guidelines that we published last year in the Annals, and I'll just give you one quick example for something that has caused a lot of controversy, or will cause a lot of controversy, is causing controversy. So this question deals with whether or not screening using digital breast tomosynthesis in addition to digital mammography should be used compared to digital mammography alone in organized programs for the early detection of breast cancer. And this particular panel made a recommendation, a guideline recommendation. So you talked about guidelines recommend to do things. Actually, if you look carefully, many guidelines recommend to stop doing things. And therefore, that needs to be looked at very, very carefully. So it was actually a recommendation to not use these two tests combined in the context of an organized screening program. So conditional against, it was based on very low certainty of the evidence. And I pulled this example because I think it's quite interesting. So if you looked, when we did the systematic review, we found one RCT that looked at breast cancer detection. There were observational studies that looked at breast cancer detection. Both of them suggested that there was an increase in breast cancer detection. And this was based on high certainty evidence from this one randomized trial in a larger number of women, obviously. And the effects were something close to about a 400 per 100,000 women screened increase in breast cancer detection. So this all looked good. If we take the example of the benefits only, then one would have possibly made a recommendation in favor of the dual screening strategy. However, the guideline panel also looked at the downsides. And interestingly enough, there were several unknown downsides that made the panel much less enthusiastic. So for instance, the false positive recalls, interval cancer, which is down there below. All of this is available on the European Commission website, so that at the end of the day, the evaluation of the actual potential benefits and harms indicated, well, we really do not know how large these desirable effects are. I'll get back to that. We don't know how large the undesirable effects are, despite the fact that there was one randomized trial, because we didn't know what increased breast cancer detection actually means. Is that overdiagnosis or something else? That there were, the certainty of the evidence was very low, that there were large costs involved. So we talked about the consideration of costs by guideline panels needs to much improve, but it is routinely done by many guideline panels. The certainty in the resources that are utilized, and then the issues around equity, acceptability, and feasibility, which we felt clearly varied across the setting. But the point is that on this basis, the guideline panel made a conditional recommendation against the dual screening because of the uncertainty that was involved. It seemed that the undesirable consequences outweigh the desirable consequences for the time being. This was explained in detail, lack of information about key outcomes such as mortality of valid surrogates, incidence of advanced stages. All that we had was the detection of breast cancer. So that consideration around the importance of the outcome and what really matters to women is front and center in modern guidelines. I'll share my last example with you. This is an example that is hyperacute. It's an example about the treatment of venous thromboembolism in COVID-19. You've probably all heard that that one of the possible causes for increased mortality and the increased need for invasive ventilation may be related to the fact that patients develop, in particular, microthromboembolism, but also just regular venous thromboembolism. And so the big question is the risk really elevated? And should we use, in patients who are admitted, in particular those who suffer from hypoxic respiratory failure, should we be using stronger, that is therapeutic, anticoagulation? Those of you who have treated patients with VTE, with COVID-19 in the hospital, in particular those who got sick, probably have faced this question. So whether or not you should use low dose, for instance, low molecular weight heparin, or intermediate or therapeutic dose, low molecular weight heparin, or be it a DOAC, in order to help patients or prevent patients from dying or going into respiratory failure. So these are two radiographs. So you see these patchy ground opacities here that affect the peripheral distribution. And then here, this is a more pronounced case, ground glass opacity. There's lots of interlobal thickening here. Obviously a concern and a problem for patients. So we did a guideline with this just was presented 3 days ago, literally, with the American Society of Hematology. The draft recommendations are out there with regards to whether or not, this is the question, DOACs, low molecular weight heparin. Could you mute yourself? Yeah, thank you. Whether or not therapeutic or intermediate level anticoagulation should be used compared to prophylactic intensity in patients with COVID-19 related critical illness, who obviously have no other indication. In other words, they don't have a VTE yet. So we formulated our PICO question and we looked at the evidence. And this had, as you know, already made it to the media that there was increased risk of VTE And as I said, the big risk was that now we start treating patients with higher doses of anticoagulation, which potentially obviously cause more bleeds. Anyways, what we found was very interesting, despite the fact that COVID-19 seems to have surpassed, in terms of research publications, topics like atrial fibrillation and so on, and despite the fact that most of us believe that there would be good evidence for increased risk of VTE, we could not confirm this on the basis of the available evidence. We found very little evidence. Moreover, we found also very little evidence for any potential benefits of higher dose anticoagulation. In other words, there was one study for the key outcomes that we identified, talking about the patient important outcomes, right? One study for mortality, one study for PE. You see how small these studies are. One study for proximal DVT, and then one study dealing with major bleeding as a potential side effect. The point is that all of this evidence was rated as very low certainty evidence because there was risk of bias. The studies were not randomized, so that includes the risk of bias. They were very imprecise, and there were potentially other problems with them. So we rated this as very low certainty of the evidence for the potential benefits and downsides, and ended up, because of the bleeding risk still being substantial, to recommend against intermediate or therapeutic intensity anticoagulation. So against doing more, because the evidence simply does not support it for the time being. We are doing a living systematic review and a living guideline, a living recommendation. So we will constantly update this evidence over the next year in order to see where the evidence will actually point us. I wanted to just mention one other thing without showing an additional slide, but we have created with the GREAT working group a number of paradigmatic situations that allow, in particular, recommendations against doing something or against an intervention on the basis of very low certainty evidence that are summarized in this table, which is very hard to read. But I'm just putting it here, given that I think the talk is recorded, and therefore people can go through it, can stop the recording to understand what we are talking about. But we've developed a framework of paradigmatic situations that allow recommendations against an intervention on the basis of very low certainty. That's one thing that I wanted to show. I wanted to show one other, I think, success story following the TB example. The WHO TB department now regularly uses full evidence to decision frameworks and makes these full evidence to decision frameworks for its recommendations public. And then finally, a paper that may be of relevance to you in particular, as we're talking about the COVID-19 pandemic, that these type of assessments, both of the evidence to using evidence to decision frameworks, even if rudimentary, and even if they are put together rapidly, are necessary for transparency, because otherwise those who use your recommendations don't understand them. There is oftentimes no documentation on what to disagree if people disagree on recommendations. And that type of evidence assessment and the transparency of going from evidence to recommendations matters regardless of what timeframes are actually available. I will conclude here just very quickly. So with a few summary points. So we actually use guidelines that we use guidelines in order to inform us about practice. They are both for and against particular options. There's lots of things that guidelines cannot do cannot do for us, and that is to be certain about interventions when the evidence is actually uncertain, such as in the thromboembolic example that I provided for you. There's lots of standards for trustworthy recommendations, and I think choosing wisely and good value healthcare can be directly derived from those recommendations that are actually trustworthy. And a fundamental piece in the puzzle are actually some form, be it the GREAT evidence to decision framework or another evidence to decision framework, is an evidence to decision framework that allows us to both understand a recommendation and adapt it to our particular circumstances. Thank you very much for your attention.
Thank you so much, Holger. On normal circumstances, we all be clapping, but you can't see that, but I'm clapping for this fantastic communication. It is really a new, in a certain way, it's a very structured, very impressive way of looking at these problems. And when we start 25 years ago with the movement of evidence-based medicine, here in my country at least, we were not expecting this level of integration of knowledge in a very operational way to take good care of people. So I really thank you for giving us this overview, even though because you're expert in several areas that not only produce evidence, but also use it, implement it. And that's precisely that view that we were looking after. So thank you very much for your presentation. It's now open to discussion, questions, comments. Please just get in because I can't see everybody. There are so many that I can't see everybody. But if you want to write something on the chat, or if you just raise your hand, I'll try to. Okay, I have a question here on the chat. Dear Holger, thank you very much from Tamara Milagre. Dear Holger, thank you very much for your great presentation. Misconception in clinical guidelines is the most dangerous waste in healthcare. Don't you think that the involvement of patients, representatives is mandatory to improve the value in patient-centered healthcare? She is a patient advocate for hereditary cancer.
Yeah. So I would say my brief answer is, but I will, well, let me give a differentiated answer if that's okay, Antonio, because I think
please do. Please do.
The brief answer is yes. The brief answer is patients are one of the key stakeholders in healthcare. They are indeed most of the time the subject of the recommendation. Of course, they should be involved. They should be involved in a guideline panel. They should be involved as a regular panel member. Our experience is that many times they operate at exactly the same level or above those of other panel members, depending on obviously how well they are engaged. So the brief answer is absolutely yes. However, there may be exceptions, right? There may be exceptions when it comes to, for instance, public health issues, because then everybody around the panel may be the person of interest, right? And you might not specifically have to select certain groups that represent patients. There's a few other scenarios, so we've played them through. Some people make the argument, if you're talking about hospital policies, for instance, around infection control, it is not necessary. It might not be necessary to have certain stakeholders in the room because of the type of evidence that is discussed. But in general, yes, we actually go through great lengths to identify patient representatives, and basically in all the guidelines that I've done over the last 10 years, patients were involved. However, they are at the same risk as anybody else around the guideline panel, at the same risk of anybody else to have interests that prevent them from being impartial. And therefore, as was mentioned before by Minna, we've made big advances in dealing with conflicts of interest in trustworthy guidelines. The issue around conflicts of interest is equally important in patients, in particular because we've dealt with many patient representatives who were actually supported by patient organizations, who were supported by industry, and therefore had a preset agenda as well. So that's my answer. But in general, I would say, yes, they are in particularly relevant for phrasing the right questions, helping us understand the patient perspective, et cetera, et cetera.
Thank you, Holger. The floor is open for more questions, comments, please.
May I have just a very short comment and question?
Yes.
Well, first of all, thank you so much. I've been deeply involved with guidelines. I'm a past president of the European Society of Cardiology, which produces a lot of guidelines, and so I feel comfortable talking about the subject. But we should acknowledge also, and I think you've mentioned that in a very nice way, the limitations of guidelines. And guidelines, they are guidelines, so they are orientation for clinicians, and they are not the law. Although in some countries they're being used now, by the way, by even in the court of law to they've been using, start to be used, and that's something that we have to keep in mind when producing these guidelines. But that's the first thing, you know. It's an orientation for the clinician, and we know today, and we have data, and that's one of the comments I would like to clearly stress, that guidelines, following the guidelines, if they're done properly, saves lives. And that has been, of course, I'm familiar with the cardiovascular ones, but we have a lot of evidence demonstrating that if following the guidelines, the outcome is better. And that's evidence for the evidence, which is very relevant. But my question to you, we've had a long discussion in Europe about including health economics in it, because of course it's not the same one recommendation in the country, and I'm not going to say any names of countries, so I won't be perceived as with prejudice, but you know, it's not the same in one country and the other, because of course, obviously the economics of each country. So how do you see, because I know that's a long discussion and you as an expert, how do you see the introduction of health economics standards or analyses included in the guidelines in a way to help to improve, let's say, the accuracy or the focus of guidelines according with the different regions, different countries, different financial conditions or economical conditions of each country. What's your view on that?
Yeah. So again, just the general answer is, thanks for this question, by the way. The general answer is that the consideration of cost does require the definition of the perspective. I will just say that again, right? If you're taking an individual patient perspective in your clinical practice guideline, which I don't advocate you do, or anybody does, but some groups do, then cost may be very simply dealt with by leaving it to the patient to decide, right? You should still lay out what the potential costs are, but for instance, in systems where interventions are covered, then the single patient doesn't worry about costs. It's not the approach that we advocate. So integration of cost and in particular resource data in guidelines, I think, is critical, because everything depends on cost, right? It is naive to ignore cost in healthcare provision because resources are limited. So having said that, what guideline panels can do, international guideline panels can do, is oftentimes not the full economic analysis, including all the sensitivity analysis, because it goes beyond the budget, it goes beyond the time that for instance, a professional society has available for developing the clinical practice guideline. But they can lay out the considerations for others, because you can have the best health economists around the table. If they don't work with the clinicians or with the decision makers around what really are the outcomes, what needs to be considered in this context, the best economic models fall apart. The ideal scenario is, and we've done it for some WHO recommendations, the ideal scenario is that you utilize the results of the evidence review that informs the guideline, and you do your modeling with sensitivity analyses around for the different settings that you are considering. So different drug prices, possibly different resource utilization data that get integrated. And then, speaking hypothetically, just to answer this question as well, what's our dream world? And I think we are getting there slowly. The dream would be that we would have, and some health economists believe in this, that we have generic models that we can provide together with guidelines, generic models where context-specific data can be integrated, and these type of cost data, the contextualized cost data or resource utilization data, could be utilized for those who then implement the recommendation. And in other words, the European Cardiology Society would make a recommendation saying, you know, assuming costs like this, we would suggest doing that. If costs differ, then, you know, plug it into this model and see how that recommendation possibly differs in your context. That's, you know, we are not that far away from that, quite honestly. It sounds like we are, but many guideline groups are going in this direction, and I think we should be looking at this in a very, very positive way. But to answer your question, health economic data, super important, will be context specific, laying out the considerations, making the assumptions transparent will help those who, for instance, use ECS recommendations in the European context from Italy to Norway.
Thank you. More questions, comments? Please just get in. All right, Holger, let me ask you this. Looking at the speed of production of evidence, for example, you gave the example of COVID-19 having a higher number of papers than atrial fibrillation in just 7 months. And even the speed with all this data is coming out, one of the major problems is actually updating all these guidelines. Do you defend, is it your opinion that we should perhaps centralize globally the methodology to do the systematic reviews and analysis that are then used to support decision making, to support writing up the guidelines to support decision making? Is this a good idea? Does this make any sense?
Well, so first of all, I think centralizing evidence synthesis and sharing and collaboration is key, right?
Yeah.
I think COVID-19 just makes it a little bit more pressing. But, you know, honestly, my approach to it has been, the problem has been there for a long time, right? It's just making it more, it's just making it more overt to people. That's the first, but yes, it would be ideal. I mean, this is why Cochrane was created, right? It was a repository of systematic reviews. Now, there is some benefit to duplication of systematic reviews, but it probably shouldn't go beyond 2 or 3. Just to make sure that whatever the first group did is real, and then Antonio, it goes far beyond that, I think, because we typically think of evidence synthesis as addressing intervention effects, but our problem right now is actually evidence syntheses that deal with the other criteria. You know, we talked about cost, we talked about equity, we talked about feasibility and acceptability. And if we would get 5 less groups doing the same intervention effect review and focus on these other types of reviews, I think we would be much helped. And that central collaboration and coordination, I think, is critical.
Okay, all right. Thank you very much. Okay, we have still time for another one final question or comment. Please just, step right in, because I can't see you all. Comments? No? Okay then. If nobody wants to ask any other questions, I would like then to thank you all very much for this fantastic talk. We really appreciate your help. Thank you, Mina, for your talk also. We are very grateful for you guys to make up the time to be with us in this late afternoon in Portugal, at least. And we look forward to talk to you in the future about these subjects. I will now switch to Portuguese, if that's okay with you, and I apologize to the international listeners. I'm just going to say goodbye in Portuguese to my country fellows. And so, once again, thank you very much. Bom, queria só, no fundo, agradecer a todos e a todas a vossa presença aqui no nosso webinar. Este webinar foi construído e pensado precisamente numa perspectiva semelhante à que o Instituto de Saúde Baseada na Evidência foi criado, ser uma espécie de uma organização guarda-chuva, debaixo das quais múltiplas organizações podem trabalhar connosco, entram e saem nos trabalhos utilizando aquilo que nós temos para oferecer, mas ao mesmo tempo permitindo todas as criatividades diferentes das diversas instituições. Isto na parte da investigação científica, mas também na parte da formação. E, portanto, parece-me que este dia hoje foi particularmente, na minha perspectiva, feliz porque conseguiu dar essa ideia de que, de fundo, há múltiplas organizações com múltiplos objetivos diferentes que se podem juntar a discutir e a refletir sobre problemas comuns. E, nesse sentido, nós queríamos muito agradecer a vossa presença, queria agradecer à professora Ana Paula Martins, como Presidente do Instituto de Saúde Baseada na Evidência, o ter-nos ajudado a construir esta nossa reunião. Queria agradecer ao Dr. Miguel Guimarães, como bastonário da Ordem dos Médicos, sítio onde está sediado o Programa de Estudos em Linguagem de Portugal, e todo o apoio que ele tem dado a este programa, que tem tido um sucesso considerável, e a todas as pessoas dos colégios da Ordem dos Médicos que, no fundo, escrevem e publicam estas recomendações, e, finalmente, ao Grupo da Cochrane Portugal, do qual eu sou o diretor, agradecemos a todos o vosso apoio até hoje e, no fundo, tudo aquilo que a gente vai também, vem também pensando sobre todos estes assuntos. Prometemos que periodicamente iremos fazer este tipo de webinars abrangentes, com temas porque também sejam importantes para o último dos stakeholders que nós achamos aqui muito importantes, são os doentes. Repito aquilo que disse há bocado, o Instituto foi criado desde o início, com a ativa presença dos doentes. Para nós isso é muito importante, porque no fim do dia o último objetivo de tudo o que a gente faz é o bem-estar e é a melhoria dos doentes, e portanto, e não só dos doentes, e dos saudáveis também, não é? E portanto, para nós é muito importante esta parceria ativa, colaboradora, e que para nós tem sido também uma experiência muito, muito interessante e muito confortante, perceber que podemos de facto estar muito próximos uns dos outros nestas decisões. Este tema é um tema transversal que nos pareceu muito importante, penso que